Okay, fourth speaker, Dr. Ros Vallings. Ros is in medical practice in Auckland and has been working for 35 years with patients suffering from chronic fatigue syndrome and related conditions. And she's also involved as president of the national organisation supporting people with chronic fatigue syndrome. So please welcome Ros Vallings.
Thank you. Right, well, thanks very much for having me. And I'm going to give you a bit of a history lesson to start with, actually. I, as Peter says, have been involved with this illness for a very long time. And I first got involved working with a rheumatologist in Auckland, Dr. Peter Gow, who's still around. And we did some research looking at these patients using exercise. And that was 1977, I think. But anyway, just to give you a bit of history, this illness was first described, and I'm talking chronic fatigue syndrome, by a Greek philosopher Hammurabi back in 1800 BC. And we're therefore looking at about 3,800 years of history of this illness. He described it very accurately. There have been a number of outbreaks of infections over the years, and they've stood out as leaving a number of patients seriously afflicted or affected with what we've been talking about today as medically unexplained symptoms, but I think the explanations are getting a lot clearer. The Royal Free Hospital in London had an epidemic of a very severe flu-like illness which affected mainly doctors and nurses back in 1955. I was at the London hospital about 5 years later doing my training, and we had a lot of these doctors and nurses coming in still ill as inpatients, and I would emphasize they were medical people. They had been very exhausted at the time of their illness, pressing on far too many hours probably, not allowing proper recovery. The illness was probably something like infectious mono, and we were investigating them in the infectious diseases department of the London hospital, trying to find out what was going wrong, and it really was medically unexplained at that stage. The whole illness then went through a really psychiatric phase in the 60s, where the psychiatrists McAvity and Baird were focusing on this being a psychological illness, mass hysteria it was described as. And bear in mind, several years before this, multiple sclerosis was described as hysterical paralysis. So the history of that illness was quite similar in the early days. There's a lot of research going on now in quite prestigious universities, and I think the understanding of the illness, and I'm talking chronic fatigue syndrome, which I think is very different from what a lot of people call chronic fatigue. I think we've kind of branched off, if you like. So what was I doing in the early years? Well, first of all, I was seeing a huge mixture of fatigued patients, and people were sending them to me kind of in desperation because they knew I was interested. And these patients exhibited a multitude of symptoms, much as we've already just heard about in this session. And many of them, we ended up with psychiatric diagnoses or mixed diagnoses, a number of things wrong with them. And a lot of these patients had been treated in various ways, but they really were treated with skepticism and were often told, well, all your blood tests are normal, so there can't be anything wrong with you. And of the initial bunch that I was seeing, probably about a third, we did end up with different alternative diagnoses across a huge spectrum of possibilities. But 2/3 of them did fulfill the criteria for a diagnosis of chronic fatigue syndrome. And those days we were using the criteria set up by Fukuda. We had a presentation of all ages, all severities, and an incidence of about 3 per 1,000. Coming up more to the modern day, these are the sorts of things we're seeing now. The majority of patients will have started their illness with a viral illness, and the large large percentage will be infectious mono. I see many, many patients now who have the typical story of glandular fever. 2 or 3 months, the majority should have recovered, but at 6 months, a number of them are still quite ill with a lot of those symptoms. And the symptoms that go on are often mimicking their original illness. Some of them, of course, many, many other infections, such as bad flu or chickenpox, all sorts of things. And there's a continuum of severity from very mild through to very severe. We now use the Canadian diagnostic criteria, which were formulated in 2003, and these have been formally adopted in the UK now. And it's fair to say that this diagnosis cannot be made in the presence of an untreated psychiatric illness. So what are the core symptoms? Well, certainly fatigue and myalgia. Post-exertional malaise is the very typical symptom that pretty well every patient will describe, and if they haven't got post-exertional malaise, they probably haven't got chronic fatigue syndrome. And this means that they will often manage exercise really well, perform quite fit, but the next day they will suffer and maybe not be able to go to work. They cannot get off the bed. And there's a lot of research now showing why. Many of them will have headaches, and many of them will have frequent sore throats with lymphadenopathy. And the lymphadenopathy is often very prominent in the neck. And a lot of them do suffer from orthostatic intolerance, and most of them have a non-restorative sleep. They'll say things like, well, I've slept for 14, 16 hours and I'm still not refreshed. And sleep studies have begun to show why. A lot of other comorbidities in the differential diagnosis, and I've seen people with all of these symptoms, or all of these disorders, and sometimes, of course, we as a result do change our diagnosis. So it's a kind of ongoing process seeing these patients, and I'm not going to go into any of these things, but they are conditions that one does see reasonably regularly. Current research is really pressing on, and there's some very, very good research coming out of prestigious universities. And I'll talk to you a little bit about the research coming from Griffith University on the Gold Coast in a minute. But there are very, very good studies coming from all over the world now looking at these various aspects, which I haven't got time to go into today. But the stuff coming out from the Griffith University seems to be very, very important and is becoming acknowledged internationally as being extremely important, and probably some of the most important research we've seen in relation to chronic fatigue syndrome. I won't read the whole thing, but impaired calcium mobilization and dysregulation of the transient receptor potential melastatin, 3 ion channels in natural killer cells. I'm not an immunologist, so for goodness sake, don't ask me what all this means, except to say that it's thought that it's an inherited malfunction. It's an unusual immunological finding, apparently, and it means that calcium fails to move properly into the natural killer cells. And these levels of calcium movement have been shown to be considerably worse in the more severe patients. This particular team at Griffith have actually gone out into people's homes and taken blood samples when they're at their most severe. And then the very much more recent research is coming out from a guy called Navio and his team, which includes Ronald Davis at Stanford, and they have found 612, they've investigated 612 different metabolites and found significant abnormalities, which make it seem almost like hibernation for some patients, what they call Hypo metabolic syndrome, or what is called in animals that hibernate, Dauer. So how do we manage these patients? Well, Again, much of what's been said this afternoon, this morning, has been very relevant. We need to validate the illness. We validate that these people really are unwell, that we're not just telling them it's all in their head and there's nothing wrong with them. The patient and the family do need to be educated, and I have handouts about this condition for my patients. Stress management, really, really important, because we all know that stress aggravates every illness in the book. A cautious exercise plan whereby they do enough exercise to begin to become more mobilized, but not so much that you push them towards the post-exertional malaise. They've found a number of abnormalities now in the muscle mitochondria that account for that, and if you push the mitochondria or the muscles too hard, the patients do suffer for it, but they can gradually rehabilitate. Diet, well, no special diet, just good eating, and trying to get them to stop spending money on the latest cure that's out there. So many supplements, so many thousands of dollars spent. And then I have a great emphasis on sleep and pain management. I use tricyclics a lot for sleep management and gabapentin, pregabalin for pain management. In the longer term, I think these patients do need to be managed generally in general practice, not be going the rounds of endless investigations once one is fairly sure of a diagnosis. They may need a multidisciplinary team at the beginning to try and sort things out, but general medical care, very, very important. They tend to blame everything on the illness that they've been diagnosed with, and I think that's true for every illness in the book. People still need to have regular cervical smears, prostate checks, and all the rest of it. Ongoing surveillance, really important, because it has been shown that people with chronic fatigue syndrome do have an increased risk of certain cancers, particularly lymphoma. The aging of the telomeres on the chromosomes have been shown to be greater, so these patients may well die younger, and we do have to be sure that our diagnosis is correct, because so often we can easily make mistakes. So after 40 years, I've seen about 6,000 of these patients now, and I think it's fair to say that they can all experience a better quality of life with a firm diagnosis. That's really important for them, compassionate care and a multidisciplinary approach. And the patient really does need to feel in control of their health rather than their health or their disease controlling them. Two resources I would commend: the Physician's Primer put out by the International Association for Chronic Fatigue Syndrome. This was probably 3 years of work by a team of immunologists and physicians from around the world. I was involved in that, and we used to meet on Skype every fortnight for about 2 years, and in New Zealand it had to be about 5 in the morning to fit in with everybody else. Japanese people involved too, and the primer was finally produced and is available to download and gives some really good, sensible management strategies. And more recently, in June last year, we had done a similar thing, completing a pediatric primer. You don't need that great big long website. You can just put in CFS pediatric primer and it comes up. One of your Australian colleagues, Catherine Rowe from Melbourne, was one of the lead authors in that, and she has been working in chronic fatigue syndrome with children for probably 30 years now at the Melbourne Children's Hospital and has seen thousands of children, has a very big clinic, so she's a very experienced person. Thank you very much.